check the volume.
Check the volume.
And Dr. Mayo, can you hear us?
I can hear Dr. Miles in the background. I can hear him at.
Okay, good. That's the main person.
Yes, sir, it is.
Call the meeting to order. Dr. Kelly will do the invocation.
Let's pray. Dear Lord, we come to you today as humble servants. We understand the gravity of our discussions and decisions today. And above all, we pray for your wisdom as we make these decisions. Just be with us today. We're humble and blessed to be here. Just thank you for everything you do. In your name we pray. Amen.
Now the pledge. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Well, it's good to see everybody here today. I'm glad the word got out. This is not an open hearing. This is an open meeting. This is a working meeting of the Board of Medical Licensure to go through and take all the input that we got from the hearing and from the hundreds, if not more than that, emails and from the telephone calls at 1 o'clock in the morning and all the good suggestions we got, and we've incorporated them as best we're able to into these regulations about prescribers and opioids and benzos. So this is a culmination of all the information that we've obtained, and we're going to go through these and see if the changes work. Now, believe it or not, it's hard to have a working meeting of a board where you have to have open meetings every time. You can't. This is a big group of people to have a working meeting. You're fixing to see one. And do all of y'all have the? Well, then you missed them. They were out there. We can get them. I'd like to announce that our court reporter today is Miss Dawn Stubblefield. Thank you, Dawn. Good enough for this. So, we're going to start with the discussion of the changes of the proposed regulation in Title 30, Part 2640, prescribing and dispensing. And it starts on page 1. Does anybody have any comments? Mainly definitions. As you can see when you look at these, this is our working copy. In the margin, you'll see comments, you'll see questions, and this is how we do this.
Dr. Miles, we further defined, and I think it's probably the same as licensee as any person licensed to practice by the board in the state of Mississippi who has prescriptive authority. Okay?
Right. That's Rule 1.2E.
Dr. Riesling, I know somewhere discussion was had regarding this rule may not apply in certain circumstances to inpatient treatment. Have y'all, you define inpatient treatment?
Yeah,
We'll get there.
Okay.
Everybody's happy with page 1 down through K. Page 2.
Mr. President, I wanted to make a suggestion that we add a definition of inpatient, and it would go something like this: use of PMP does not apply to an inpatient setting. However, upon discharge wherein a prescription for a scheduled medication is written, PMP must be run prior to discharge. And then we would say, and we might say this prior to that, sentences, inpatient means a patient in a hospital, comma, nursing home, comma, long-term care facility, comma, or inpatient hospice. Now that's inpatient hospice, not outpatient. Or any other facility wherein medications are dispensed to a patient by a third party who is duly licensed and are certified to dispense dispense medications at a healthcare or related facility. So that hopefully clears up that if they're in an inpatient facility, running a PMP while they're in the hospital, and all the other stuff does not apply. But it would apply if they leave the hospital with a prescription sometime prior to discharge.
And that would go in after K and before, what was it? This will be L and then there's M.
M would be
Bariatric
bariatric medicine,
okay.
and you'd just make this L, I guess, in terms of the definition. Somebody taking notes on this?
Right, as fast as I can.
Wait, is pain management practice K, isn't that K, and bariatric is L?
Yeah.
Yeah, we just changed it.
We just put a definition for inpatient.
Oh, so you, I know, but you're putting, okay, it's not at the end, you're sticking it in the middle.
Just sticking it right above bariatric
Okay, I
medicine.
got it, okay.
So, and this is to make it consistent, because at that point in time, you'll be writing an outpatient prescription.
Correct.
That would be,
I think the rest of that page is separate.
And another example would be somebody comes in the emergency room with a kidney stone. You don't have to run a PMP before you give them IV morphine for the kidney stone. But if they leave the emergency room with a prescription, you would have to have a PMP run prior to them giving the prescription that they would get filled outside and would dispense to themselves.
That brings us down to Rule 1.3. I think we added there to maybe delete low modal testosterone.
Now, that's on the top of page 3, where it says, those licensees whose practice is not a pain management practice as defined previously must actively utilize PMP upon initial contact with a new patient at least every 3 months thereafter on any and all patients who are prescribed, administered, or dispense controlled substances other than opioids. And then you can just put a sentence in, this does not pertain to low modal, testosterone, and Lyrica.
I would again, like to make a case for, Allegra D, Sudafed containing products.
Now, again, that was the whole point of the statute that was passed 4 or 5 years ago, is that this pseudoephedrine is the primary ingredient in the methamphetamine labs. And when we passed the law, we went from 350 methamphetamine labs a year to now 2 or 3. And so I think it's important to know when you write a prescription for Allegra D, is your patient getting it from 2 or 3 other providers. The only way you would know that is to run a PMP. Now you can get refills on that, so you can write Allegra D and give them 5 refills, and if they come back 6 months later, you'd have to run a PMP then. So,
Do you feel like the regulations that exist are sufficient for that, or do you feel like this is necessary on top of? I guess it's the only other question that I would have.
This doesn't hamper the regulation that's already written, right?
No.
So this won't affect and let more labs.
you're talking about
open up.
what's already written in statute?
Yeah, that's not gonna be changed if we include this, I guess.
Statute just says that a pseudoephedrine containing medication, you have to have a prescription for it.
Yeah.
So you can give somebody 5 refills already, but you don't know if that person's coming to you and getting Zyrtec D with 5 refills, then going next door and getting another 5 refills, to another town, getting another 5. And then you accumulate, so.
Well, I think what I'm thinking more about is there's a big push for antibiotic stewardship, and a lot of people show up with the acute upper respiratory infection, and having an option is more what my thought was. It's not for those people that get 5 refills, but I'm just making my case.
Well, I think, this doesn't prohibit anybody from getting a pseudoephedrine containing drug, it just says you have to run a PMP before you write it, so, I mean.
Well, I guess my only question would be the information that that you are saying that we would have access to by looking at the PMP. My question is just with the current regulations that exist. I mean, so it did what we've accomplished, at least with the pseudoephedrine containing medications. We've accomplished that goal, right? Because we've already knocked that down. So the question, my only question would be, is what we're doing with regard to that classification of drugs enough? And, or do you really foresee pseudoephedrine abuse as being a big enough problem for us to address it in this way as opposed, I mean, it doesn't mean that people who are writing, I think there's nothing wrong with saying if you're writing it, you might wanna know, I think if you're writing anything, you wanna know what other medications people are on. But from a regulatory standpoint, I just was wondering if you're not already accomplishing that by what has already been put in place with those medications.
The question is, are we gonna be running PMPs on folks that it will probably get run on them anyway for another reason? Or ones who might be problematic?
So this means we'd be running a PMP on somebody who came in with a hiccup.
If that's all they have.
If they got a pseudoephedrine containing drug.
Yeah.
But we've done the good we've done without a PMP, right? Just by making it a prescription only drug.
Labs that way, so I don't know that adding those drugs to people who have to have PMD would give us any additional help in that battle.
Well, I can tell you, I still see a lot of crystal methamphetamine addicts. Now, where they're getting it, I don't know.
But they gotta have a prescription for it.
Yeah.
So what does the board want to do on this?
I would exclude
So you're gonna add them to the list?
Yeah.
So how do you say we're gonna exclude Lomotil, testosterone, Lyrica, and pseudoephedrine
Containing co-medication.
Okay. I would also suggest that down the top of the middle page, it says, in addition, licensees are required to register under this section must also utilize PMP to generate a global report. I think we'll do away with that global report. I don't think that's gonna be,
Agreed.
so let's strike that. And then rule 1.3, under this, says does not apply to inpatient settings where orders for patients are administered by a third party in said facility. I think we'll do away with that because that's kind of being redundant. We've already defined what inpatient is. And rule 1.3 has a lot of stuff in it, such as you have to have a DEA, you have to be, have to sign up to the PMP. And if we leave that in there, that somebody could use that to say, well, I'm exempt. So I think we'll take that out.
Basically, you've already addressed that.
Yeah.
Yep.
Okay, what's next?
1.4, names of records and inventory.
Just go over page by page.
Section by section.
Section by
Page
section.
How far does one board go? How many pages?
Page 7.
Through page
Yeah,
7?
7.
Okay.
There's a redundant spot on final page 3 where it says, it shall be subject to all applicable federal statutes and regulations controlling such practices. On page 4, it says, protest solicitation must meet all applicable federal statutes and regulations. That may be saying the same thing. The one's about distribution.
new thing, that's not something we added, that's been in there 15 years. I just, kind of goes without saying that you gotta follow federal law.
Just says it 4 times.
Free to borrow the federal law.
Get it.
Rule 1.5.
On records.
Can I ask a question, page 5? The bottom of page 5?
Good faith.
5, page
Yeah.
5. You see
Page
a
5.
list of situations where the doctor must determine whether or not the prescribing or the examination is in good faith.
Right.
You have 1, 2, 3, 4 is that physician dispensing or prescribing drugs to patients having no medical need. When the physician, when the licensee knew or should have known that the patient or addicted. What about abusing? That's addicted. Definition of addicted cover abuse. I think they're two separate definitions, are they not?
Yeah, these would be broader.
So you said addicts or abusers.
Yeah.
Yeah.
And or.
We're addicted to and or abused.
So, and this was brought up before at the hearing, is this actually, because it says factors used in determining the existence of good faith, but then there are things that are listed that are kind of clearly things that would show the absence of good faith. So I think that section in itself is very confusing. I think we need to figure out what we're trying to say and probably articulate that better. Well, yeah, figure out which side of the fence to be on. Because then
Yeah,
you
1
have
through
both.
5 are exceptions to good faith.
That's exactly how it appears. but-
No, it says,
Well, these are factors which would be considered by the board to determine if.
Determine if.
Some are
Yeah.
positive.
And they're not
Some are
good.
positive and some are negative.
Yeah, that's okay,
Okay.
when you're looking at factors, it's like
Yeah.
on the good
So
side,
good, yeah.
on
Oh,
the negative side.
But you have
I think that's when they say may include, but are not limited to.
Just read this paragraph.
Right.
Yeah.
It does say include but not, may include but not limited to, but when you talk about the word addicts, I do the addiction and abuse are two different distinct
You may want to
definitions.
say, yeah, I agree, Stan, you may want to say, and know that the patients are addicts and/or.
And you can say or
Using.
or misuse or
Or misuse.
abuse. Because I think that there's a continuum
How
that
about
may
abusers?
start with misuse and
Maybe misusing, not to the point of abuse or misuse.
Misuse, okay.
so, for the thing of good faith, you could say some of the factors used in determining the presence or absence of good faith. I think that makes it more, yeah.
what y'all
Good
say?
suggestion, I like that.
Take out existing.
Some of the factors used in determining the presence or absence of good faith may include. That way that you can have positives and negatives in the list.
So you're gonna take out but are not limited to?
Oh, you're going to leave that?
You
You
can
can
leave
leave that. Existence.
Take out existing.
Straight out existing.
Okay.
Presence or absence.
Presence or absence.
And so under point 4, we'll reword the knew or should have known. We'll need to reword that to reflect misuse, potential misuse or addiction.
You got that?
Right.
That takes us to the bottom of page 6.
I don't think there's anything in that.
So, we're now through with 1.4. We want to have a motion, have a second, and go on the. Well, I think you take it section by section, then. 1.1 through 1.4.
So moved.
Second.
All in favor of these changes? Thank you.
Thanks.
I didn't know what that was.
Sorry about that.
So now we're on page 7, 1.5, use of diet medication.
So I have one recommendation, on page 9C. A licensee is not permitted to prescribe, order, or dispense controlled substances for the purpose of weight reduction or treatment of obesity greater than a 30-day supply. And so I propose that we add to that an exemption for board-approved bariatric practices may extend the use of controlled substances such as leucocerin and Qsymia for 90 days. And
You
then-
want to say such as, but not limited to?
Yeah, because it's something
Maybe
that
something
comes
you
out.
Medicines that come later on.
And these are essentially non-stimulant.
Well, Qsymia does have a very low dose of stimulant in it. It has topamax and 3.75 milligrams of intermediate in it. But it is indicated for long-term use, and they have studies going out a couple of years. And so in the vein that obesity is a chronic illness and recurring, that's the thought.
So is it,
Well,
what's the is there a specific class that it belongs to, or is there a way that we can create the carve out and still
Those are
maintain?
What I was gonna ask you, if we're gonna make an exception for them because they're specialists, why do we need to write anything? Let them do what they do, they're specialists. And not
You
make-
mean, say exemptions may apply for, board-approved bariatric practices? And also in the 30 day, the next thing was in D, the 30-day, reevaluation. There's a sentence that says once medically established goals have been met for an individual, the need for ongoing medication should be reevaluated and documented in the record. And so the thought was that the board recognized bariatric practices might reevaluate every 90 days instead of every 30. So we could change that and not put in any specifics, just board approved.
Reevaluated and documented.
We need to make sure that the language is what you said, Jenny, that it's the exemption applies to certified bariatric practices, not board certified bariatric physicians. Those are two different
Oh,
things.
yeah. It's board approved
Yeah.
bariatric practices.
Is it relate that back to the definitions though? L, we have a definition of bariatric medicine, medical weight loss, or weight management practice. If those are what we're talking about, we can reference and say we're exempting all those as defined in 1.1L.
Oh, yeah, that's a good idea.
If those are what we're talking about.
And we want to change
What's
this
M now?
from 30 days to 90 days.
Yeah, for board approved bariatric practices.
Is M, is that what those are?
It's L is on to M because,
That
yes,
is, okay.
yes.
You may want to reference that definition.
Bill? Let just lose Bill.
Let me ask you a question,
Sure.
Patients sometimes get referred in from primary care doctors, specialists, and the specialists send back referral and follow direction. I'll follow them again.
Yes, but the majority of people, primary care doctors do not want to manage these medications, the majority.
But Dr. Brunson, you can, as a primary care physician, and correct me if I'm wrong, you can continue to write that as long as you're not exceeding the 30%.
Well, what I was
Thing,
wondering
yeah.
is if I'm a primary care physician, I refer my patient into a specialist, and then they wrote the consultation and evaluation with recommendations back to me, continue the patient on this regimen, I'll see them back 6 months to a year. They are then actually following the recommendations from the specialist, which would then suggest to me that they can write more than that because they're going off the referral of the specialist. That's why I'm asking.
I think that you have a valid point there, because, there are situations that does happen. But that doesn't make the primary care doctor above the 30% at that point, which makes you a bariatric practice.
Well, what I'm saying is.
Can they
then
write
can
it for
write
90
They can write it
days?
for more than 30 days, because it follows the recommendation of the specialist at that point.
Yes.
For that patient.
Yes, yes.
Well, you could do what we're gonna do later on, what I'm gonna suggest later on about the pain management, about methadone, is put, the exemption is in a certified bariatric practice and/or the result of a consultation with a certified
Yeah.
bariatric
Because I
practice.
think what we want to do is, we want to get the primary care physician as much help as they can get by sending them to specialists. But the specialists can't keep all these folks in their practice. But they can write the consultation and recommendations back to the primary care doctor. At which point in time, the primary care doctor is really following up on the recommendations of the specialist. And as long as they're doing that, they should put them on the guidelines of what the specialist has, if they're just refilling or whatever the prescription.
If you can
That's
see
my
the person
question.
comes and says, can you refill my meds, because they're seeing their primary care, their PCP more frequently, they're out of their meds, they need a refill. What you don't want is somebody to be freaking out about what's in the letter of this and whether or not they are gonna be penalized for just kind of doing the continuum
Right,
care.
but they cannot follow the specialist recommendation because of
Yeah.
the constraint we put on them.
Right.
Good point.
So how you want to work it?
Just put and/or.
I just had a good thought on how to write it.
I think probably,
And/or result of
and/or result of consultation.
Right.
Yeah.
I think they need to go back to the weight loss specialist once in a while. I mean, if you've been writing this for 3 years, they might have needed to have been back. So,
Charlie,
yes, sir.
what about consultation and ongoing collaboration with?
There you go.
Like
Great,
that.
Bill.
Because we've already said with the specialist, it's 90 days anyway.
Yeah.
So there's still some guidelines.
Consultation, ongoing collaboration.
The high altitude must have helped your thought process.
That's definitely.
That's all I had.
Yes.
So we put that in. Ongoing collaboration. Next section, 1.6 is bariatric medicine and weight loss.
There wasn't a lot of comment about weight management.
Except about this part. It seemed
There were
like
some
everybody-
comments about the 100 hours.
Right.
But I
Just
think
those
that's,
seeming
that's
things.
not a bad thing.
Y'all be careful about talking over each other, I'm just thinking, I've got a court reporter over here, making faces.
Okay. Sorry.
Dr. Marsh, maybe we want to go ahead and approve 1.5, 1.6
Yeah.
before we move on.
Let's go ahead and approve 1.5, then we can move on, I can come back. Is that your motion?
And 1.6.
Or we had done that yet.
Well, there's nothing in there.
That's all.
Still waiting.
Yeah.
Approve 1.5 and 1.6, motion.
So moved.
Second.
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 All in favor, aye. Can we strike out this whole paragraph on medical spa and wellness? I don't see anything left in it.
Well, it was just a few
It's just the
sentences.
definition.
It just means that if you do weight management, you got to be, approved.
Rule 1.7, use of controlled substances for chronic, non.
I wanted to suggest that we put, after Rule 1.7, use of controlled substance for chronic non-terminal pain, period, then put, Rule 1.7 is not intended to exempt licensees from Rule 1.4, parentheses, which is maintenance of records and inventory. That just refers you back to the things you have to do before you can write a scheduled medication. On a, in this case, for even terminal patients. But that would just, again, refer you back to 1.4, it doesn't change anything.
Is there anything that suggests you would be exempted from it?
Well, yeah, if you've got Rule 1.7, says use of controlled substance for chronic non-terminal pain, and let me see. Well, for example, it says documentation in a patient record must include a complete medical history and physical examination, supporting studies and reports of consultations. Well, if you say this pertains only to chronic non-terminal pain, then if you're treating someone for a terminal or cancers or terminal pain, then you don't have to do a physical exam, you don't have to document things. That could just be a misinterpretation of what this says. So, again, it just refers you back. We know it doesn't exclude it, but just to make sure people understand that, it gives you a reference where to go back to. And then there's a thing on page 13, Dr. Miles, number 4, which is under this section. The last sentence under 4, I guess, it says, this consent must also include specific requirements of the patient, such as using one licensee in pharmacy, urine, serum, medication level monitoring when requested, pill counts and grounds for which to determine the treatment. And we've changed it to must be terminated, and we're going to suggest that it say should be terminated, which would give the licensee some leeway that they may terminate the patient from practice or they may not. It's kind of like the second chance thing or third chance. So change.
Not should, but can.
I think so.
Whatever.
May.
be terminated.
So you're going to take must and put may be
Can.
terminated.
And those situations where the practitioner just, after extensive violations, failed to terminate the patient, that's an issue that can be brought up by the board.
Well, you know, if you give somebody, if you're treating them with buprenorphine and they've got a positive drug screen, you want to give them a second chance, that's one thing, maybe even a third chance. But if you look at somebody's record in over a 2-year period, and we actually have a case like this not long ago, where someone's had a positive drug screen for cannabis, and they've been given Suboxone time and time and time again, and obviously they're not staying clean and sober, then we can say, what are you doing here? But it doesn't mandate that you have to drop it.
So what, in that case, what would, which is something I've always wondered about, what would you do with the patient? What would we expect or want the doctor to do with that patient?
Not
Well,
a referral to a pain practice. You can't.
Because they're addictive, right?
well, this,
This is talking about just the consent and the contract. This is just documentation when you enter in that kind of treatment
Right.
relationship with the patient, that there needs to be a level of accountability that is very clearly explained, defined, and that there's a record kept of that conversation and what those expectations are, so that it's known. So this is not saying.
May.
Yeah.
Okay, I agree, maybe. Thank you for explaining that.
okay, Dr. Miles, on page 14, number E, I don't know, the second or third sentence says, these circumstances include those patients obtaining controlled substances or other drugs having addiction form and addiction sustaining liability from more than one licensee. By definition, that would only be those licensed by the medical board, so we need to change that to any other healthcare provider, which would include nurse practitioners, dentists, who are those people we don't license. In other words, if you see that this person is getting controlled substance from some other healthcare provider instead of just a licensee.
That's E.
Yeah, E.
More than one other healthcare provider.
We're just taking a licensee out and putting healthcare provider. in that one sentence now. Then under F, we keep those first several sentences the same, which basically refers to section 21 USC 823, which is the buprenorphine section, which allows you to write a scheduled medication for someone who's addicted to an opioid. After that sentence, it says nothing in this is not a change, nothing in this paragraph shall prohibit a licensee from administering narcotic drugs to a person for the purpose of relieving acute withdrawal symptoms when necessary while arrangements are being made for referral for treatment. That actually allows a licensee, if they detect that their patient is addicted, to set them up with some sort of a step-down program within the confines of their practice, and that may last a week or 2 weeks or a month or whatever, until they can find appropriate treatment for them. The treatment may be an inpatient, it may be going to the mental health center or whatever. So I think that alleviates, or goes along with, to alleviate the concept of we're just dumping somebody that's addicted and not giving them any medication. So I think that's okay. Now the next two sentences, not more than 1 day medication may be administered to the person or for the person's use at one time. Such emergency treatment may be carried out for no more than 3 days. I think we ought to excise those two sentences, and then that allows to do some outpatient step down. If you take those two sentences out, then the last sentence says nothing in this paragraph shall prohibit the licensee from ordering, prescribing, administering, or dispensing controlled substances in a hospital to maintain or detoxify a person as an incidental adjunct to medical and or surgical treatment of conditions other than addiction. So if you have someone who comes in the emergency room with a fractured hip or ankle, and someone runs a PMP and you find out they're a doctor shopper or whatever, but anyway, it becomes clear that they have some addiction, it allows the physician, if necessary, to prescribe narcotic medications to relieve the pain in the hospital or to even detox somebody in the hospital setting. So it's all congruent with what we said earlier. And that's no change. That's just a clarification of what that says.
Hey, Randy, can we go back for a second? And I apologize, but I'm trying to take in what you said about me. Can you, like, in a nutshell, sum up what the purpose is of E, what it really says? Because there's been some strike-throughs and other things, and then you have recommended the whole changing the licensee back to the healthcare provider. Can you just, for me, kind of summarize what this specifically is addressing and what we're really, what the specific aim is of Section E?
It says no licensee shall order, administer, dispense, or prescribe a controlled substance for treatment of chronic pain to any patient who has consumed or disposed of any controlled substance or other drug having addiction form and addiction sustaining liability other than in strict compliance with the treating licensee's directions. In other words, you're treating, as I read it, you're treating someone for chronic pain, and they come in and you run a PMP and they're getting medication from other providers, then let me see, she'll order this controlled substance for treatment of chronic pain. This is acute pain. To any patient who has consumed or disposed of controlled substance or other drugs having an addiction form and addiction sustaining liability other than in strict compliance with the licensee's directions. These circumstances include those patients obtaining controlled substances or other drugs having addiction form and addiction sustaining liability from more than one, that says licensee, but we're going to change that to healthcare provider, and those patients who obtained or attempted to obtain new prescriptions for controlled substances or other than have an addiction form and addiction sustaining liability before a prior prescription should have been consumed according to treating licensee's directions. In other words, you get a prescription early from someone else.
So it just, because
That's why I wanted to hear it out loud, kind of, because as I was reading it, I kind of got lost in it.
Yeah.
And so, and I'm not sure if the intent is for this to, because I think this needs clarification, because is this saying, when you run the PMP, you have a patient who has a chronic pain issue, and I'm just gonna throw something out, sickle cell patient. And that patient has a known chronic pain problem, and you see that somebody else has written them a narcotic, and say they've given them a number of pills, and you determine that if they take it according to the way that it is written, they should not be out of their medication. Is that then telling you that you cannot, right? Because it says nobody should order, administer, dispense precautions. Does that then mean that you cannot write them up?
Well, the next sentence says this requirement will not be enforced in cases where a patient has legitimately temporarily escalated a dose due to an acute exacerbation of their condition. The treating licensee,
But you gotta document it.
level documents that the escalation was due to recognized indication.
I think I'm like,
It's awful wordy, I agree.
It is, I think that we could probably,
I might have to
Make that much
word.
later.
I am.
okay,
We'll
what you
see if that'll cover that.
got? Because I was just in trying to figure out what this really means, it's a little confusing.
Well,
to me,
he
and I-
says if they don't follow the rules, you can't give them any more narcotics. But F says that you can give them medicines for detox so you can refer them.
But the question is, because, so what that to me is saying that is that there's kind of the premise that everybody who runs out of their pain medicine early needs treatment, and everybody might not need treatment, but this concept of temporary escalation, and, I mean, it just seems really murky.
What it has here is repetitive or continuing escalation. If they run out of medicine early, 6 months in a row, then
The question is, how do you get there? So say the first time they say, well, I had a really bad day, you know, or it rained, my joints are aching, so I took more medicine. Then they come back, and so then, is it the second time? Is it the fourth time?
I don't know that, I don't know that we can go that far to legislate that.
I know.
What I tell
That's
my
why I'm
patients, and I've got some sicklers that do this very thing, is if you escalate your dose and you run out, then you need to come and see me and not go somewhere else.
But I mean, what that does then is we're really kind of, so the spirit of this is really to minimize the number of providers who are treating the patient's chronic pain, and really not to penalize the one person who may be willing to do it, because I think we all have encountered, especially now, in the midst of what's going on, there are fewer physicians who are willing to write, and so for the people who are, there's a lot more scrutiny, and I think people are reluctant or hesitant to be that person, and I just worry about those folks who are out there who do have chronic pain and ill issues, and making sure that they are gonna have somebody who can do it, and that doesn't always have to be the, chronic pain or pain specialist, but because like for our HEMOC colleagues and those kinds of people, that's something that they deal with quite frequently. I just wanna make sure that those people will have a place and that people aren't afraid to take care of them.
Well, yeah, of course, HEMOC doesn't apply because it's cancerous.
I mean,
But the other thing is, if you've got somebody.
sickle cell's not cancer.
Well, yeah.
Chronic pancreatitis, sickle cell.
Yeah, if you're treating someone for chronic pain, they ought to be on a stabilizing dose, and then if the pain escalates for whatever reason and they decide to take more, then you're not required to take them on, kick them out of practice. You just have to have that conversation. Then you wonder how many times you're gonna allow that to happen. That's at the discretion licensees.
And I'm just using like sickle cell because these people do have issues and they see lots of different doctors. But like, for example, they can't see their hematology. Like I have patients who I share with hemonc. Sometimes I write their meds, sometimes hemonc writes it. But many times these patients will end up in an emergency room. And so it gets a little sticky when I'm just concerned about the wording here and the limitations that this might create when we check that P&P and being very directive about what has to happen when we find what we find, because we probably won't be able to cover all of those situations. And I'm not in any way being critical of this, I just feel like we need to be clear about what we're trying to do.
I think all this says is that it's a reason for concern and a time for reevaluation of your treatment plan.
But this says that no, but we start out with no licensee shall order, administer, blah, blah, blah. And under those circumstances, when we're pulling those reports and finding some discrepancies. And I just, it just gives me pause. And I might be, if I'm off base with it, or if I'm thinking about it wrong, I'm welcome for you to
Well,
redirect me.
if you go back to the definition of chronic pain, I don't see sicklers as chronic pain. They have acute pain episodes. But I have not, in my 30 years, seen a sickler that was in pain 24/7 all the time. Now,
But I guess,
and I've always seen that as being acute episodes that may be more often for others.
So I guess I think that, and I guess that might be an interpretive thing, because I've always seen them as, that's like a chronic pain syndrome. Those people, because I even tell them, if you expect to be pain-free, you'll probably have more days where you will have some degree of pain rather than not. You might not be in excruciating pain all the time, but I think there are quite a few people who suffer from that and other illnesses who do have some degree of pain on a daily basis or more days out of the week than not, and that is their reality.
And they're gonna have it their entire life.
Exactly, and it's through no fault of their own, but that is a part of their condition.
I think the last two sentences clarify, gives discretion to the physician to handle it, and clarifies the first paragraph. And I think you're gonna have to look at each case on a case-by-case basis.
This requirement not be enforced in these cases.
But I just want that
acute situation
conversation to
comes
be,
up.
I want it to be out
So-
there, because I think it's important that, I just don't want people not to be able to get the medications that they need, because we are trying to respond to folks who have come to depend on these medications when they don't really need it. That's, making
I
that
think the
distinction
out is
is
written in
important.
the second half of this paragraph.
So the problem.
Roger indicated he has some suggestions, do you have that?
So would this sentence cover it though, Michelle? This requirement will not be enforced in cases where a patient has legitimately, temporarily escalated the dose due to an acute exacerbation.
Well, I mean, I see that, but that's not all of it, right?
And then it
It said
says
if it
that's
was your
repeated
recognized
in this
indication.
matter.
So you just have to document it and,
The last-
Correct. But then it says, in a reevaluation of the treatment plan shall be undertaken by the licensee, which I don't know who that's gonna be, like, who's gonna be the person who's really responsible? But that's fine, okay.
all right, we, back down to, we decided we were gonna take out those two sentences, not more than 1 day and 3 days, and leave everything else the same.
You're an H?
And
Yeah.
Yeah. And that finishes page 14.
Section H, you
Yeah. I think, Randy, you had some changes in H.
Well, what,
I think we were changing the number of jump days.
well, that was your suggestion.
Oh, that's my suggestion.
We were gonna do the 3, I made a note that we would do the 3-day, but you could have 7 with the refill as you follow the regulation. But then there's been some conversation that would say 3 days and go to 10.
But what I was, I had a couple of recommendations here. One was to insert that every licensee must review a PM, and that's after we changed the 7 days to 10 days. And then mine's take off from there. So my addition to this paragraph would be every licensee must review a PMP report of each patient encounter in which a Schedule II medication is prescribed for acute pain or chronic non-cancer pain. PMP reports may be run by the licensee's designee, which I think we said again. Now, when issuing a prescription for a Schedule II opioid for outpatient use, a licensee shall limit the prescription to a 10-day supply. Prescriptions for greater than 10-day supply of Schedule II opioid may be written to treat the patient's acute medical condition when needed in the professional medical judgment of the licensee, and the following conditions are met. The duration of pain is expected to exceed 10 days. The condition is documented in the patient's medical record. The licensee documents that no alternative to a Schedule II opioid was appropriate or sufficient to abate the acute pain associated with that medical condition. And then I wanted to add an ongoing section to that is, this section shall not apply to Schedule II medications prescribed for pain associated with cancer diagnosis, pain experienced while the patient is receiving palliative care, or medications designed for the treatment of substance abuse or opioid dependence. What I'm trying to get to here is trying to put all of the specific do's and don'ts about what we're recommending here in one section. So it's clear to our licensees when they look at it, they don't have to look at multiple sections. This pretty much clarifies it and puts it right there for you to just look there and see.
Or do you suggest that we do with the initial statement of discouraging more than 3 days, but then allow?
No, I think we can discourage more than 3 days. And so that'll at least get our docs to think about most traditional acute pain going to, you got toothache, you got something like that. That pain's probably, the acute part or the deep pain probably in 3 days or so like that. And so we just want them to think about that. But then that best medical judgment, if they think they need longer than that, then they have the option to do it. And we're recommending a 10-day. If they're going to go more than 10 days supply, then they have to meet these other criteria. If I've had a major surgery, and then they can just write in the note that I'm prescribing because of this reason, these are the things, criteria that are being met. And my best medical judgment, a 10-day supply or a 20-day supply will not control this acute pain.
What you're allowing for, instead of a 7, you're allowing for a 10-day, and then you can do a federal regulation. You can do an additional 10 if you think it's necessary. So it gives you 20 days. I don't have a problem with that.
But also, the other one is if you know it's going to be longer than that, then you have an option, but you have more requirements to further clarify why you do.
I don't understand the thing about the opioid dependence, because again, those are all Schedule III medications.
Well, I mean, if we think that's covered and that's not going to.
Well, this is pertaining to Schedule II medications.
Okay, well, that's Schedule III, take it out.
Now, methadone is a Schedule II, but that's federally regulated, so whether we address that or not, that's,
But,
do that. But that's for opioid addiction. If you want to leave
there
opioid
was some, because I think we have had some questions about that. Does this sentence create an issue then with the federal regulation? If we left it in?
What about opioid dependence?
Yeah.
No, I don't think it does, because there's nothing we can put in this or take out that's going to supersede the federal thing. I'm just suggesting that it's unnecessary because all the medically assisted treatments are Schedule IIIs. But if you want to leave it in there, that's fine. It doesn't really not going to affect anything. So you got that note to add in there.
Yeah, we know. Oh, Jay, the next one. What are you talking? The one I just read. What we finished with that?
So add that, is that gonna be H or?
That's H.
I mean, your addendum is gonna be an addendum.
Well, I had an H and an I. I had H, about this, till I can see must review the PMP. Because we've had it in there, but it's gonna write them right in sequence, HI, and then I have to check. That deals with benzodiazepines, or is that another
Yeah.
section?
That's,
That comes in I?
that's I. What I was gonna suggest that we add on I, we're saying that you can't prescribe opioids with benzos and or soma, and then we're saying with the exception of acute injury requiring opioids, at the end of such concurrent prescribing must be documented appropriately in the chart. Patients are currently on established regime. Concomitant opioids and benzos may be allotted a reasonable period of time to withdraw from one or both substances. And I was gonna add, or suggest that we add, prescribing opioids concurrently with benzodiazepines and or soma may be allowed only under very limited circumstances in which the combination is used to treat very specific chronic medical conditions for which there's no other treatment modality available. And that deals with the issue that the physiatrist brought up about the spasticity and so forth. And I think that's a legitimate concern. And that would not, first of all, in my opinion, that wouldn't be in almost anybody's practice other than a subspecialist in physiatry or maybe neurology, something like that. So, that's what we're talking about. Again, this is dealing with a combination of opioids and benzos. If you're writing somebody benzos for a chronic anxiety and they have an acute pain episode, they can be given opioids for the acute pain episode. But they really shouldn't be on benzos and opioids long-term, in my opinion, if the only, you have to ask yourself, or the prescribing physician have to ask, why are they on the long-term opioids along with benzo? They have a chronic anxiety problem, fine, then let's find another way to treat the chronic pain. But if it is a situation of which there's absolutely no other treatment modality, then you can make a case that you can do that.
So have we spoken to when you're just prescribing the benzos?
Sir?
Have we spoken to when you're just prescribing benzos?
No, we haven't gotten there yet.
So are we gonna leave the verbiage at, a contraindication period?
Where are you?
Just on the first part of I, which is read in the beginning of the blue paragraph?
Well,
Are we gonna say relative, or are we just gonna say that when prescribing, it is a contraindication?
Well, you're saying it's contraindication, and then you're going back and exempting a few situations, and the exemptions would be if you're on benzos and you have you have an acute episode of pain, then you can prescribe for a limited period of time, and that's up to the licensee's discretion. The other would be if you had a chronic medical condition for which there was no other treatment modality, then you could have them on both. But that should be very limited.
So so then basically what we're saying is, if there's somebody who, and I'm just totally coming up with crazy things, so say anxiety disorder and break your leg. Looking at this, the way that's written, it says opioids for either chronic or acute pain, there's a contraindication, it says contraindication.
Maybe we should put relative.
Which is why I just feel like we kind of need to maybe.
Well,
When you go to Hippocrates, it's a black box warning, so is that a contraindication or is that a relative contraindication? I'm asking.
after the first sentence, the second sentence says, however, opioids and benzos may be prescribed concurrently on a very short-term basis in accordance with section H of this rule when an acute injury requiring opioid occurs. We've got to keep in sight that 30% of the opioid-related deaths, benzos are on board. And I think if we say it's a relative contraindication, we're going to continue to have the same problem we have. You allow people to use it under certain circumstances.
I appreciate that, but I think that those kinds of things need to be heard, because I think the problem that we see is that people will see bullet point right, and they might not read the whole paragraph, even though that may be what they're responsible for. I just want everybody to kind of have a clearer understanding of what the spirit is of this law and how we are framing the letters of these regulations. It's a source of concern. And to turn around and say something's contradicting, however, you can do it for a little while. To me, that's kind of almost the same as saying a relative contradiction.
What do we need to rephrase that to say that concurrent prescribing of benzodiazepines and opiates carries a black box warning, which is what?
I mean, and the truth is that we are
that's
trying to
what it
discourage
is.
it. That's what we're trying to do. It should be discouraged. However, we do have to recognize that there are circumstances that arise where it is appropriate and makes sense. And I think that's really what we're trying to get at here. And I don't know if this may be the best way we can say it. I'm just asking the question because now's the time we gotta figure that out.
Do it, because if you do pull up any benzodiazepine, you pull up in Hippocrates, it says opiates, black box warning.
And I think that there's a misperception about the combination of those drugs. I think that people believe we have become because those medications are so widely used, so readily available, everybody knows at least 5 people who are on it, and they kind of get passed out like Skittles. I think that there are a lot of us, even who are healthcare professionals, who kind of are a little numb to the dangerous combination of these meds with opiates. So I get that, but I think that like when people are reading these regs, they don't always understand what's behind it. And since we have all these people here and we're talking about it, I think those things need to be put out there so that there's more understanding about what it is that we're really trying to accomplish. So that's why I asked the question. And how we say things matters. We know that by our last year. How we say things matter because people are going to take this and they're going to practice according to it. So,
Well, I can't imagine anybody getting 5 hours of CME prescribing without hearing time and time again that you shouldn't prescribe benzos with opioids. But anyway, but if we added that last part there, very specific chronic medical conditions, that's my recommendation.
Yeah, I think we make it known that we believe that that's a fairly risky combination to use. And if you're going to do that, you should note that there's a higher risk profile, and then maybe there ought to be, like we're talking about, if we let you write more narcotics, there ought to be extra notation in the record as to why you do it. Maybe that would.
All the recommendations I've read from the CDC and all the stuff that's come out in the last 2 years, I don't know if the word contraindication is used, but it's certainly dissuading. It's equivalent to that. I mean, nobody is saying you should write the two together unless it's an acute situation. I just think taking contraindication out waters it down.
I think either say change I would think add the word relative is probably appropriate, because it's not an absolute contraindication, it's a relative.
And I think I think when you say relative contraindication, you understand that that's something that we, a terminology that we use in medical practice.
Right.
That basically says in and of itself, this is something that under routine circumstances you probably shouldn't do, but there are some extenuating circumstances in which you need to or you must, and in those instances you do.
Well, if we put relative in front of contraindication, then there's no use in having the rest of it about using it on a short-term basis or using it in chronic medical situations.
I think that's explanatory.
That should all be there.
No, I think you should keep it. I don't think that needs to be stricken, but I just think that when you say contraindication.
Or should we add a relative contraindication that should be used with caution?
Or,
That's what
I was
Education, that's not good.
Exactly, that's my point, is that when you say it's a contraindication, then that's when people stop. And the most important, I get that it's important that we get this right, but the other part is how it's gonna be interpreted. And what you don't want is the person who takes a Xanax every night to go into the ER and somebody say, oh, it's contraindicated because they Board of Medical Licensure said it in their regs. And then all of a sudden, there's confusion out in practice about the implementation of what we're doing. That's my concern. I know we're not gonna be able to circumvent all of that.
Well, maybe I'll just call it what it is, it's a black box warning, which is what it is, in print. And, on electronic media, maybe I'll just say concurrent, prescribing of benzodiazepines with opioids carries a black box warning. However,
Well, I think if you put relative contraindication there, and you can put in parentheses black box warning to prescribe opioids, that just highlights it's a black box warning. Let it go as it is. Leave the rest of it in there.
okay.
Say that again?
But just put after, if you put relative, say relative contraindication, and you put parentheses, black box warning, into parentheses, to prescribe opioids concurrently. Just highlight that it's a black box warning.
And Rita, I hope you understand, I'm not trying to steal your thunder or take away or water down what you're doing, because I agree with it 150%. But the other part is I just want to make sure that when this stuff gets rolled out and people are actually doing it, that they don't get confused and that we are very clear about what we mean and don't leave too much of, like, they're supposed to be in our head, because there are a lot of people who are going to be impacted by this, who are not sitting in this room and who might not have the benefit of this conversation, who are going to see contraindication and they're going to say, because I don't want to get the letter in the mail, I don't want to come up and get called up by people.
Well, I don't want to think in relative contraindication and say that somebody had epidemic disease 2 years ago, in the same light too. I like, Randy said, put relative contraindication, parentheses, black box warning, which puts it in the right frame, and then add, like you said, the short-term exception for the legitimate spasticity concerns where the treatment modalities are not.
So what we're doing is we're just putting relative in there, and putting black box, and then we're adding that additional stuff toward the end.
Right. Does everybody agree with that one section?
I don't agree with it, but that's.
Friendly
amendment. I mean, you know, I'm just saying, when you put relative in front, of it, you're flying in the face of every medical group that's put out, including the CDC, that it's a contraindication. So that's what.
But then you go ahead and say, but you can use it in this circumstance. Well, then it's not a contraindication.
Okay.
That would mean you would never use it, right?
Okay, all right.
Okay.
Go ahead.
Does everybody agree we're gonna put this change in there like this? I have a motion.
Second.
All in favor? All opposed? Thank you, Phil.
We didn't finish
Just
that
that one
section.
section?
We didn't finish that section.
That's just with the friendly.
That was just I.
That was just I. We haven't gone over the rest of it.
Randy,
On J, at the end of J, it says, in addition, licensing required to register in this section must utilize PMP to generate a global report. That again, let's do away with the global report. All right, now K, I have a suggestion. Point of service drug testing must be done each time a Schedule II medication is written for the treatment of chronic, non-cancer, non-terminal pain. Point of service drug testing in PMP review must be done at least every 90 days for a patient prescribed benzodiazepines for chronic medical and or psychiatric conditions which are non-cancer, non-terminal. And add on that, point of service drug testing shall not be required for hospice patients. And then put, point of service drug testing must include, you can put at a minimum, or must include opioids, benzodiazepines, amphetamine, cocaine, and cannabis. Which is basically, that's not the 9 to 5, but it's basically the 5 that you're gonna be looking for. Most bottles are gonna have more than that, and it's not gonna be a price differential, but at least it has to have at least
And the
that.
price on that is
$2.50,
$2.
$3.
So if I order the cheapest one, it will cover this.
The cheapest one covers that, right?
Yeah.
Okay.
Okay, quick question. You're carving out hospice here. What about that earlier provision that you inserted during the definitions, dealing with inpatient care?
Well, you
Point
don't,
of service drug testing for inpatient pay.
you know, this doesn't require point of service drug testing on any inpatients.
Okay.
So you're really talking about outpatient
Yeah.
hospitals?
Outpatient.
But you exclude point of service drug testing for outpatient hospitals.
Yeah. True.
I want to make sure that is clarified, I think.
But there's an awful lot of drug testing that's done inpatient at the discretion of the hospital. For example,
Yeah.
some OB services test every mother and baby that comes in for drug tests. But that's a hospital
Yeah.
bylaw, that's not prohibited them from doing it.
Yeah, inpatients do anything they want. What we're trying to clarify is if they're outside of the hospital. And so what you're really talking about now is outpatient hospice to be, in line with everything else that we're doing here is outpatient.
Could we exempt psychiatrists from the point of service drug testing? Because they're not used to doing lab tests in their offices.
Well, I'm really opposed to that. It's not a lab test. You pee in the cup and you look at it and it tells you what it is. I mean, it's something that, I only have an addiction practice now and I don't do any lab. I don't even have a phlebotomist, but we do 10 or 15 drug tests a day, so.
We're gonna have to educate the psychiatrists on how to do that.
The nurse can do it.
They don't have
Or the
nurses.
secretary.
A lot of them don't have.
Psychiatrist does it, nurse?
Yeah, a lot of psychiatrists don't have
No,
nurses.
no.
The secretary can do it.
Secretary.
You hand them a cup and you go in the bathroom, they bring the cup out and you look at it and read it.
That's an interesting concept though, and I think we did have some psychiatrists who talked about this with staff. I guess the other point is that, I guess the physicians themselves could also run the test together.
Well, that's really gonna affect the, therapist-patient relationship.
Really?
Just about how, in what way?
Well, if you don't understand this, I don't know how to explain it to you.
Try, because we're intelligent people, so I think that we can probably.
We all do
figure
lab
out a way.
testing, and I just don't.
Well,
So
it's like,
try.
it's like.
You're a
we-
psychiatrist, you should be able to explain this smart things.
I mean,
It's a
the
trust
majority.
issue.
Yeah.
But
That's what
but
it
it's,
is,
but
it's a
here's the
trust
thing, but if this is something that you have to do, that's not really, that it's supposed to really be in the interest of, I would think that the patient-physician relationship, you would be able to explain that to your patient in a way that would not destroy a trust relationship.
Well,
And the other thing is, if it's a requirement, that to me, I think, would actually help to make them feel better.
Well, the concern I have about that is that probably only 10 or 15% of benzos are written by psychiatrists. The large majority are written by family doctors, internists, OBGYNs, APRNs, PAs. And if I'm giving someone Xanax for chronic anxiety as a family physician, I have the same doctor-patient relationship you do. And so if we're gonna exempt psychiatrists, then we gotta exempt everybody else. We all have doctor-patient relationships, and if you wanna blame it on the board and say, well, the medical board's requiring us to do this, but I can tell you from a lot of experience, when I see people in my practice that are getting chronic benzos, it is not uncommon that they're getting a multiplicity of other medications that the prescriber doesn't know. And so that's why you check the PMP, and that's why you check a drug screen to see if if it's in the urine, and also to see if something else is in there.
Outside of paranoid schizophrenic, who might go ballistic if you have to pee and cut, and are most of those on benzodiazepines, or they on Risperdal and other things?
Well, it's mostly chronic anxiety patients, but,
Well, let me ask this question. Go ahead. So we're trying to pick up from having the psychiatrist do the drug testing is that the patient's actually taking the benzos, or we're trying to find out if they're getting something else from another physician. If they're getting a narcotic from another physician, then that person should run a PMP.
You're supposed to get the narcotic from the street while you're smoking marijuana. I think there's an assumption that, and it may be true in most psychiatric practices, that those people that are on anxiolytics are the little old ladies that go to church every Sunday and they're 80 years old. A significant number of people on anxiolytics are 25, 30, 35 years old that have some anxiety problem, be it real or otherwise. And so you're throwing out a bigger net to make sure that they're taking the medication and that they're not taking something else. And doing the test doesn't mean, there's nothing in here that says you have to kick them out of your practice or have to do something. You're just getting additional information. I mean, I think you would want to know if you were treating a 60-year-old for chronic anxiety or a 40-year-old and they tested positive for cannabis on a drug test. You would want to know that. And then you have discussion with them. And you say, what's going on here? Well, I have to smoke the marijuana for my anxiety. It helps. But it doesn't say that you have to do anything to them.
What a
So
psychiatrist.
what exactly do you want them to do with that? So say for example that happens and Dr. Lippincott tests his patient and finds out that his patient tests positive for something, whatever. I mean, is he gonna stop writing the benzos? Like, what does he do with that information? And then what accountability does he now have that he's had this information? Does he then talk to the patient? Or is there some other level of responsibility that now is that he has now like kind of accepted by having access to this information?
Well, I'm just saying that most of the people that prescribe benzos are not psychiatrists, and they have the facilities to do the drug tests, and they have the staff. To me, it's kind of like, the bariatric specialist being able to prescribe the maintenance diet medication, the maintenance weight loss medications. That's all. I appreciate y'all considering
But
that.
30% of the opioid-related deaths aren't tied to weight loss medications. And weight loss medications are not a well-established addictive medication. I mean, I treat almost as many benzo addicts as I do opioid addicts, maybe not as much, but the main thing I see is the opioids and the benzos together.
Let me ask you a question. When would a psychiatrist in a usual traditional practice do a drug screen?
Unless they had an addiction practice, probably not.
But if you had somebody on 3 Klonopin a day, every 3 months, you wouldn't want to make sure they were on your 3 Klonopin a day?
Well, maybe when therapy was initiated, but not if someone has been, there's a percentage of people who take these medications for years, and, if their PMP is okay, and I just don't see the utility of getting a drug screen every 3
Well, I
months
can see a
for
couple
20
of
years.
reasons. If somebody you have on Klonopin 3 times a day, you're urine drug screen is negative, and the kid down the street is borked out half the time, it might explain where he's getting his condom. I'd be concerned about this.
So you don't think there's a problem with running the PMP every 90 days or whatever, when you write prescription?
I don't have a problem with the PMP. It's kind of.
So would it be, going on the line of what you're suggesting as a psychiatrist, that's your area of specialty, is that you will run a PMP. If you find anything suspicious on the PMP, that will be your indication then to do a urine drug, or serum, whatever. Is that something that could?
Well,
Yeah. I'm just thinking
a
of.
significant number
What
of
their symptomatology is too, that may be something else you probably take.
significant number of the drugs that you pick up aren't prescribed medications, such as cannabis or amphetamine. And the question I would have is, if you have never done this in your practice, which you haven't, and most of us haven't, unless you do addiction medicine or pain medicine, you don't know that people that you've been treating for years aren't using other things. You don't know it until you test them for it. Now, if you do it every 90 days or every 6 months or random every 90 days, I don't know, but I just think it's, I don't know that a psychiatrist has any more expertise in picking up a patient that's being deceptive than someone else. I mean, all of us get fooled all the time, and fooled by people that we would swear would have never done what they did. So,
So them running a drug screen will pick up illicit stuff, because we already see what their own, if you run a PMP, right?
yeah.
So you're looking at then is doing the drug screen will help us figure out things that are getting illicitly or certainly somebody else's drugs or whatever. That may be some indication for them to do something.
Well, I think that if you had a positive drug screen, the indication is to talk to your patient about it. You know, if you don't ever take anybody's blood pressure, you don't know if they have high blood pressure or not.
Well, what I'm trying to
to
think through with him about psychiatrists and how it will be disruptive. We don't have enough psychiatrists, and we don't have enough folks going to see them. And we don't want to be disruptive on practice, but we do want to make sure that the public's safe. So is there some way for us to get to what we're trying to get at? With leaving them some leeway in their medical judgment to determine when they need to move on from having done the PMP, which is going to be a requirement, but maybe also on this patient, I need to do a drug screen. Can we give that leeway to them while still being keeping the public safe? That's the question.
Well, these questions came up at the public hearing, and I've been running these proposed. I've got a small psychiatric practice. I've been running these, proposed requirements for my patients, and most of the patients, frankly, don't really have much of a problem with it. But it's more a problem of logistics, like small 1 or 2 person offices, and it's gonna take some education and planning to put in to accommodate these rules. That's my point.
Well, I think that the whole thing that we're doing is going to require some accommodation on the part of hospitals and practices to do any of this. And quite frankly, the less degree of accommodation is going to come about on the situation you described. Because you give somebody a cup, you say go in the bathroom, they bring the urine out, and they put it wherever you want to, and you look at it. That's literally, you're talking about a 15 to 30 second thing.
And the other question is, who's going to pay for it?
Well, the patient's going to pay $2.50 extra every 3 months. And we seem to have no qualms writing expensive antibiotics for people that have viral illnesses day in, day out. Somebody goes down to the drugstore and pays $75 for a Z-Pack, which they probably don't need. That's okay, but
some doctors are already going to be planning on how much money they're going to make off of these required drug tests.
I'm more on whether or not this is going to affect the doctor-patient relationship in that very sensitive type of a practice. That's what I'm more worried about. And if that's going to be a problem,
It's gonna be a problem in some small psychiatric practices. That's my concern.
You just said that you talked to your patients and they didn't seem to have a problem with it.
Most of them don't, but, you know, it's, I understand that people are dying and we're all gonna have to make some accommodations.
Well, I think again, it's giving you information that's, you know, that's valuable and it really does no harm. It's not any significant expense. And I think if people did it over a period of time, they'd be surprised at what they found.
I think we'll agree that all of these things are a bit inconvenient for everybody, but we got a problem we're trying to solve, and it's gonna cost some inconvenience.
I guess as I'm thinking, I can make exemptions in my own mind about those kinds of practices of not requiring the drug screen, but requiring the DMV.
Any other comments on section 5? Oh, section what? K.
So was there a?
Let's finish it, please.
Wait, no, before you move on, so, Mr. President, could you please just summarize where we are on this?
To summarize this, some psychiatrists, only one that's spoken up so far today, said that this is gonna be an inconvenience.
Right.
It could jeopardize physician-patient relationship in certain circumstances, and he doesn't have the facilities to easily do a urine judgment.
So then, how does that impact where we are?
I heard that part, I just was trying to figure out.
None?
Okay.
So
D.
language.
So there have been, because I thought Dr. Russell made a suggestion, but,
No.
so we are not going to make any changes to what's been proposed at this point.
I think we ought to make a decision on whether we're gonna require drug screening in psychiatric practice.
Well, again,
All right, how about this?
I think-
I make a motion that we do not require drug screening in psychiatric practices, unless the psychiatrist determine there's a need to order a drug screening,
I'll second that.
something like that.
Any discussion?
Mr. Harris?
If that motion passes, are you opening the door for every other practice to come in with some reason that shouldn't apply to them?
No,
Our goal, I think, is to protect the public at large
It is.
and not big little pockets that don't need protection.
But what in my mind, what I'm suggesting is we are protecting the public by not negatively impacting people who really do need to get in and have that treatment. If in fact that's gonna deter folks from getting the mental health help that they need, then that's a public issue. And
Would you want your motion to only apply to small practices that do not have the means to conduct the drug test?
I would leave it up to the psychiatrist to make that determination in their practice. That if they making them run a PMP, so they ought to be able to see if they're getting certain drugs from other physicians. And if in their professional judgment, they're suspecting a patient may be getting illicit drugs from somewhere else, then their medical judgment as a professional in that discrete kind of practice, they will determine I need to get a drug screen.
One other group that I hadn't really thought about was the mental health, community mental health centers. They have one psychiatrist and 1 million patients. You know, how's that gonna work? You know, that's another thing just to think about. And personally, as a primary care physician, I would like for the psychiatrist to write all the benzodiazepines. And that would, it shifts some from primary care to, more psychiatric care. I don't know if that'll happen, but it'd be nice.
Well, there's not enough psychiatrists. Most of the mental health centers, most of that's written by mid-level providers.
Yeah, but I'm just saying, you know, that's gonna be another step for community mental health centers too. Not that that's not a reason to do it, but it's a consideration.
But they all have collaborating positions, so
Yeah.
their practice should be similar.
Just from personal experience, I'm not a psychiatrist, but I certainly deal with these patients. And, you know, there was 2 weeks of pain when we implemented the policy. There was our staff, which I realize I'm gonna have more staff than probably a small psychiatric practice, but it was painful. You know, patients are frustrated. But as soon as the any policy change, whether it's urine drug screening or anything else, once it's implemented, then after that first time that patient comes in, they now know what the rules are moving forward. So it should be medicine. If you have that proper doctor-patient relationship there, then things are going to continue to benefit from the patient, but there will be more education on each side. Just everybody being honest. And I don't see anything wrong with it. And that even in a small practice, I guess maybe some psychiatric practices don't have a bathroom. Is that an issue? You know?
I think everybody has got a bathroom.
Well, the other thing about that we haven't talked about yet is if you've got somebody that's on chronic anxiolytic therapy, whether it's by a psychiatrist or a family doctor, and you interject a periodic urine drug screening and they object to that, don't do it, that tells me volumes. They don't want to be drug tested or something. Maybe not in every case, but it could certainly be. I mean, I've had patients walk out of my office when I told them I was going to drug test.
I think what we're doing is we are, and maybe what Dr. Dickenkind is trying to suggest to us is their patients are not like the rest of our patients.
Have a motion and a
Well,
second.
we haven't finished the discussion yet.
What percentage
I've
of the
never-
population is this? What percentage?
It's a small percentage.
5-10%?
Well, possibly 25%. The people, I don't have any doubt that benzodiazepines are overprescribed across the board, but there's a small percentage of patients who have chronic anxiety conditions that really don't respond to anything but benzodiazepines, and they keep coming back. You know, I've got people that have been for 15, 20 years, and they're it's a small number, but they're stable. You know, by all indications, and it just seems kind of overkill to be getting a drug screen every 3 months for, you know, for 10 or 15 years, you know. But I did see a recent study that everybody that gets a prescription for an antidepressant, about 10 or 15% of them get a prescription for a benzo, and that's probably the thing about benzos is that once you start them, it's hard to stop them. But sometimes they're the only thing that works. That's all. We're talking about small numbers.
Well, I guess what I'm confused about, there's nothing in this rule and regulation that prohibits you from writing them for 15 years. And yet at the same time, those patients that go to a pain management practice and go for 10 years, we're requiring them to get a point of service drug test and a PMP every single time they go.
Well, are you saying that benzodiazepines are equivalent with opiates?
No, I'm saying that pain management practice, we're requiring that of those people on every visit, and it's to see not only are they taking the opioids or whatever their prescribe it, are they taking benzos with it, and we don't know it, they're getting it from someone else. You don't know what you're dealing with till you do the test, and, so.
And I understand that, you know, if you get a drug screen on somebody that's supposed to be taking Klonopin 3 times a day and it's negative, that could be a signal of diversion. I'm just raising the question that I think it's for small psychiatric practices, I think it's just a legitimate concern, and I wanted to raise that. And I appreciate your motion about that.
Well, let me ask, Leslie, in the thing that you went to recently, and you looked at some of the other states, or they talked about some of the other states' rules and regs, did any of them address this?
Some of them did address the combination of opiates and benzodiazepines. And, Phyllis, do you remember anything specific? I'm sorry. From the conference this past week?
This is not about the combination of opiates and benzodiazepines. This is everybody that gets a prescription for a benzodiazepine.
I just asked her if this was discussed.
Nothing specific to psychiatry.
So the real question is if all you're writing are benzodiazepine prescriptions and not writing other things, do you really need testing in terms of protecting the public against actual drug overdose? And if you get the PMPs and all that, every time you get an opioid, are you really, how much gain are you getting statewide and movement-wise on the overdose crisis by doing testing on benzodiazepines by themselves? Does that make sense?
And I think, I don't know how you get to the answer to that without doing it to begin with.
I've done medicine now for 38 years. And I wish I was always able to tell what my patients were on all the time. They should be on some things that I had them on. I'm not always sure they were on that. And sometimes I found out they were on something else too. And this would help to know if they were on what you had them on, and also if they were on something else that you didn't know about that might cause a problem with the benzo. And I think it's a small price to pay. It takes 15 seconds. And I think it's just a habit that they get in when they come in the office, just to urinate the cup, and you set the cup down, and there it is, and it's over. You can read that before they go in and take a seat.
You know, another alternative, and I'm just thinking out loud, is you get depth code levels on patients, don't you? Where do you send them for that?
Usually to the hospital lab or their primary physician.
You could get drug testing done at the hospital lab or somewhere else. It doesn't say where it has to be done.
It's just point of service. I thought that meant they had to go to your office.
Well, yeah, point of service is interpreted as when you see the patient, but if you had someone that had a 9 o'clock appointment or 10 o'clock appointment, and they went to the hospital lab at 8:30 and had a drug test and came to see you and you got the results right then, to me, that's point of service.
The issue you're gonna run into is when you send that patient to the hospital, they're gonna get a $250 charge, and they're not gonna pay for it. And so you'll be able to offer them a much cheaper option for $5, $10, $15, however you want to charge for it. That's gonna be much more affordable for the patient.
I think the question of it being an inconvenience or difficult to do, I think you really have to rely on the people who do it every day in their office, and it's not any of that. It's not difficult, it's not inconvenient. It's just like the people that never run PMPs say it takes forever to do it. No, it doesn't. It takes a minute, or less. So,
Yeah, my motion had nothing to do with convenience or anything. I'm strictly speaking to whether it's going to affect the doctor-patient relationship with that patient population.
Call the question. The motion was, small psychiatric
Franklin, psychiatrist, the requirement to run a drug screen.
Exempt psychiatric practice from running a drug screen every 90 days if they were on chronic. And there was a second. All in favor? All opposed? Aye. Yeah.
Wait,
That was quick.
let's do this over.
All in favor?
Okay. The motion was to exempt psychiatric practices from doing point-of-service urine tests if they were prescribing chronic benzodiazepine.
Aye.
It's been made and seconded and discussed. The question is, do you agree with that or not? If you do agree that they should be exempted, vote aye.
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 If you think they should not be exempted, vote no. No.
No.
And the noes have it.
Thank you for your consideration.
Yes, sir, we beat that to death.
One time out, recount. I think we were tied.
No.
It was three guesses.
Four.
Four.
Five.
Two.
Yeah.
Michelle's
Six,
no.
eight, and then, okay, never mind, so it can't be a tie.
Okay, section I, the use of methadone to treat acute non-cancer, non-terminal pain is prohibited. Can we change that, except in a pain practice or after referral to pain practice?
Well, what I suggest is we take out the term chronic. We say the use of methadone to treat acute, non-cancer, non-terminal pain is prohibited. And then you add the use of methadone to treat chronic, non-cancer, non-terminal pain is prohibited except within a certified, or you could just, this could be the whole thing.
The whole thing.
Except within a certified pain medical practice and/or resulting from a referral to a certified pain specialist. If methadone is prescribed to treat chronic, non-cancer, non-terminal pain, it must be prescribed by a physician only. That's my
Everybody
suggestion.
understand that? No? Okay. Okay, rule 1.8, drug maintenance plan. Labeling requirements for dispensing physicians. Prescription guidelines, controlled substances. Another page of definition.
I had a comment on G, I think it's in that section.
What page?
19.
19.
Prescriptions for benzodiazepines must be limited to a 1-month supply with 2 refills or a 90-day supply with no refills. So it will accommodate e-prescribing or mail order prescribing.
And the P&P must be checked each time a prescription for
Sorry, that's
benzodiazepine is
H.
authorized.
I'm sorry.
So you changed that to 90 days supply.
Well, it's either or. Leave the 1 month with 2 refills or a 90-day supply with no
Yeah.
refills. So basically, it's a 90-day supply either way, but it does opt for that option.
Okay.
This will help with the mail order pharmacy, try to reduce the cost.
Do we need, have we, I guess we made it clear in the other sections that, the physician's designee may run the PLD, right?
Yeah.
We just did-
That was added in there.
Prescription guidelines, all medications. longer be valid after occurrence of the death of the doctor? Okay. Freedom of choice.
Actually, no, that's you. All been there forever.
That brings us down to 1.1, pain management medical practice. One point one, just five.
We struck out five.
23. Get through the pain management practices this quick, and we hung up on I a while ago, which was
Well,
one.
I think it's redundant.
I was the second one.
I think it's redundant. I mean, it's just
Yeah.
one of the things.
So I'm gonna bring up ownership, just for, conversation. I have some concern about when we change the definition of pain management practice and who that might include. I don't know that it will change things, but I wanna have just said it out loud in case that it does. Might it include some family practice, geriatrics practices, might it include rheumatologists, things I hadn't even considered, I don't really know. But, I just wanna have us to have thought about that, before